we'll just start now with the DASH webinar of February 16. This webinar will be on population health data NL. Jochen Mierau and Maarten and Braber will be presenting here. I will introduce them later on. My name is Peter van Ooyen. I'm the coordinator of the machine learning lab of the Data Science Center in Health, DASH, organizing this session, and we have Brigitte and Femke on the background, making sure that technically everything is working and everything is ready to be presented. A little bit of introduction on DASH. Most of you will know it by now, but DASH is the Data Science Center in Health of the UMCG. We are not connected to any of the clinical departments, but we are a service that is open to everybody in the UMCG. We run DASH projects. We just had a new round where we have 2 projects selected again that will get more support to get their data science problems solved. We also work on community building, setting up collaborations, assisting in funding opportunities. So, for example, to help write data science paragraphs into research proposals. We're also looking for needs assessment. So if there are people that want to do something with data science and don't know how to start, please contact us and we'll see how we can help you in that. Part of that help can be from the machine learning lab, where we have a lot of people working as PhDs and postdocs that are experienced in data science, machine learning, deep learning techniques. So they can be of help for some of the projects. We also do a lot of education, of which the Sparkle events and now the webinars is one part, but we also are working on more extensive educational packages on AI for medical students, for PhD students, but also for healthcare professionals within UMCG. And also communication, both within the UMCG, but also outside on what we are doing in data science, AI. Keep connected to the rest of the Netherlands that are on AI. Try to show that in Groningen we're also doing a lot in data science, and also the webinars again are part of this. So that was for a short introduction of DASH. Now for all, if you didn't already do it, please put your microphones on mute. We will have the possibility to have clarifying questions on the presentation in between. If you have more in-depth questions, then we would want to wait until the end of both presentations, and then we will handle those questions. If you want to ask a question, you can do 2 things. You can raise your hand. You have an icon in the bottom of your screen, if everything is correct, with a little character that is holding the hand up. If you click that one, then we will see that you want to ask a question and we'll give you your turn. You can put on your microphone and ask your question. You can also type your question into the chat, and then we will also read them and ask them to the presenter. This webinar will be recorded and can be viewed later, so if you have colleagues that couldn't join today, they can always follow the webinar on a later moment. Of course, they cannot ask questions anymore then, but then you can always contact us or one of the speakers if there are still questions. So now we will start with the more interesting things than what I have to tell here. So we will start with a presentation by Jochen Mierau. He is the scientific director of the Alette Jacob School of Public Health and professor of public health economics at the University of Groningen. His research is at the intersection between public health and health economics, and he aims to provide data-driven insights into health disparities within and between socioeconomic groups. He works closely with societal stakeholders to bridge the gap between science, policy, and practice. So, Jochen, the screen is yours.
Thank you very much. So it's great to be here. Let me just share my slides. So I think I have about 20 minutes and 24 slides, so we immediately know that we're either not going to see the end of the slides or I have to talk very fast. Now, if you have any questions in between, you know, you can put them in the chat and we can handle them later. And I think the best thing is if you have kind of questions that are pressing because you didn't understand something, then you can do them in between, and other questions I would say are best done at the end. So I think today is kind of a combination session where first we're going to talk a bit about, let's say, what can be done with data, and then Maarten is going to talk about more about, you know, how we're actually going to get these data structures, because now we still see that often data is being kind of collected and joined and merged and linked for specific projects, but it would be better, of course, to answer these questions with joint data. So one thing I work on mainly is so-called socioeconomic differences in health, and this is also what I want to talk to you a bit about today. So if we do not make it to the end of the presentation, there's three, I think, important takeaway messages. A, that there's a socioeconomic gradient in health, which means that there's a stepwise relationship between somebody's economic position, whether we measure that by education, by income, or otherwise, and health, meaning that the higher you are on the socioeconomic ladder, the healthier you tend to be. We also see that this holds over the life course, so that early life socioeconomic adversity also leads to adverse health later in life. And we see that moving forward, actually the differences within socioeconomic groups are of such a large extent that it might be good to focus on where those come from and try to do something about that in a policy setting. So to start with, it's, I think, good to define some key concepts. And the WHO, the World Health Organization, has defined the socioeconomic gradient also to give us a bit of an idea of what that actually is. And what they say is that health inequities are avoidable inequalities in health between groups of people within countries and between countries. These inequities arise from inequalities within and between societies. Social and economic conditions and their effects on people's lives determine their risk of illness and actions taken to prevent them becoming ill or treat illness when it occurs. So there's a number of kind of important things here. The first thing is that is about avoidable inequalities. So, you know, if you take a group of people who are all the same and you follow them for a matter of time, then just because of, let's say, genetic luck or poor luck or poor faith, there will be differences in health. But some things are avoidable. And these inequities, as it says here, arise from inequalities within and between societies. So in a society in which there's inequalities in income, in other things, we will also see inequalities in health. Also, there's inequalities in, let's say, how people with different ethnicities are treated. We also see that back in health. But today we focus on the socioeconomic element. And the important thing is that these social and economic conditions affect people's lives and determine their risk of illness. And that's important because if we think about prevention, about public health, quite often we want to think about how do we deal with people before they actually are in care, and how we could do something there. And there the social elements become important, and also shows that health policy is something that's very much larger than just what goes on in hospitals. And thinking about socioeconomic differences immediately also shows why it's important to consider health in a broad way, and that health is generated outside of hospitals and not in hospitals. So to think about this for a moment, and to take, let's say, the Northern Netherlands as an example, we see also where these kind of differences come from, and also why averages are actually uninteresting. So if we look at the average Dutch life expectancy at the moment, it's 81.3 years. But averages are not particularly interesting because there's no average person. So you have to break these things down. If you break them down by sex, we see that there's already a difference of life expectancy between men and women of about 4 years. Now, if we break them down by region, for instance, here in the north, then we see that men in Pekela have life expectancy of 76.7 years, whereas women in Menemariel have a life expectancy of 84.7 years, which means that in a distance of about 80 or 90 kilometers, there's a difference in life expectancy of 8 years between men and women. And these are quite substantial numbers. So if you think about what you did in the last 8 years, that's something that somebody from Pekela is not going to do towards the end of his life. So here we see these kind of differences. But now the question is, of course, are these inequalities or are these inequities? So the question would be, are these things avoidable, or could something have been done? And what we see, of course, is that the difference between these two municipalities is that one is substantially richer than the other. So somehow, income and socioeconomic conditions seem to play into this. And this is something that we see on every scale. So we see between countries that richer countries tend to have higher life expectancy than poorer countries. Within countries, we see that richer regions have higher life expectancy than poorer regions. Within regions, we see that again. So we have this constant model where we always have the self-similar pattern that higher socioeconomic position is associated with more income. Now, this is kind of a common phenomenon, which is also says here. So we have the socioeconomic gradient in health, which is basically the stepwise relationship between income and health and as it goes. And this also says, as in this concept, that this is something that really affects everybody. Now, this has a long history in science of people studying these socioeconomic differences. So there have been many contributions from different fields. So already in the early 70s, Michael Grossman, writing in the Journal of Political Economy, showed that health is important for individuals from a life cycle perspective, and people make choices regarding their health. And for him, health was a consumption good. It's nice to be healthy, but also an investment good, that healthier individuals are more productive. And of course, the interesting thing here is that on the one hand, people with higher incomes can buy more goods that make them healthier, but healthier people also are more productive and can generate more income, which brings us to one of the big problems in the socioeconomic gradient literature, that is not clear whether healthy people have higher incomes or higher income people are healthier, or something of both is going on. And that's actually one of the key things that you try to take out of the data to understand. Now, also in other fields, this has been important. Michael Marmot, writing in the late 70s, showed in one of the first kind of empirical contributions, the relationship between socioeconomic status and health. And over time, Michael Marmot has really been associated with very many contributions about this. But also, for instance, in sociology, Diana Koo, and with many co-authors, has written about these kind of life course inequalities, showing that the different life course stages really determine health outcomes, especially later in life. So that we get this accumulation that maybe people born in poorer neighborhoods have worse chances, and over time, even though health differences at birth are very small, they really diverge over time and become much larger. So what we see is that we have kind of a past half century where this research on the socioeconomic gradient has really been pursued in quite some isolation, with people working from economics, from public health, from epidemiology, sociology, demography, and always establishing consistently this pattern of the relationship between the socioeconomic gradient and health, in health. And what we've not really seen is kind of a joint approach on this. And this is something that we're moving towards much more now. And what we also see is that there's really a lot of policy interaction here. So we see that policymakers are very interested in these health gaps. So we see also a strong interaction between science and policy, but that can also be strengthened. Now, if we look a bit into where these kind of things can come from, then one important thing is our early life conditions. So what we basically take from the literature from Koo, but also from Grossman, is that initial conditions in life can really determine how healthy you are later in life. And to give you an example of this is a paper we did a while ago in the Journal of Gerontology, where we used survey data from about 20 or 30,000 people from all over Europe, where we had retrospective data on their childhood socioeconomic status, and we also had an idea of their self-assessed mental and physical health in late adulthood. So this is the 50+ population, and in this paper we were pretty much one of the first ones to look at these relationships long down into the life cycle. So many people look at contemporaneous relationships between health and income, and we looked over the entire life cycle, and we could show, that's what we see here, is that what we see here on the y-axis, on the x-axis, sorry, is the childhood socioeconomic position. So 1 are the people with the lowest income, and 10 are the people with the highest income in childhood. And we see here men and women, and here we see the difference in depression and in general health. And there's a couple of interesting things that we see, kind of exactly like in the argument given by the WHO. We really have this relationship, right? So this is the probability, the relative probability of claiming that you're in poor health. And what we see here is that for the lower income groups, the probability of people claiming that they're in bad health is much higher than the reference group, which is the middle, and for the lower group, it's much lower. And here, if we look at depression versus general health, we also see an interesting pattern, that the solid line is the depression and the dotted line is the general health. And what it seems to be is that we see that both are affected by the socioeconomic position, but it seems that for mental health, somehow around middle income, there's a kind of a kink in this relationship, and the relationship is not as strong anymore. So we see that the relationship between the socioeconomic position and physical health is much stronger than the one between mental health. Why that is, we don't really know yet, but it was nice that we could kind of figure this out kind of in the early paper. Now, as I said, the real hard thing is to define what is causing what, because what we see is all these correlations, but what we would like to know is what is the causal impact of, or the causal relationship between health and the socioeconomic position. And there's all kinds of theories of why that could be, so we're not going to go through these in detail, but essentially there's arguments how the socioeconomic position can affect health. There's arguments about how health can affect the socioeconomic position, and there's some arguments about how they can be driven by a third factor. Now, in the end, it's not going to be just one mechanism. It's multiple mechanisms that are interacting with each other to create these things. But what the important thing is about these mechanisms is that, of course, in the end, public health is very much a policy science. So you want to design a policy. But if you want to design a policy, you really need to know not just the association, but you need to understand what causally influences what in order to design a policy to affect that mechanism and to alleviate it. Of course, an important thing is also, which Michael Marmot says a lot, is to address the causes of the causes. So if societal inequality is causing health inequalities, you have to solve societal inequalities. But I think that's a very, very good approach, but sometimes we also have to do more mundane things, and then we can also think about where this link between the two comes from and do that. And that's, of course, where really big data becomes an issue, because it's not that easy to pull these things apart. So what we did in a recent paper using the Lifelines data, which I think many of you know, so we have all the health outcomes of people later in life, and what we can look at their conditions early in life. So we know that children from low-income households, is what we just saw in the paper that we did across Europe, that they tend to be less healthy later in life. But now if we want to understand whether or not that is a causal effect or it's just a correlation, we somehow need to give people randomly amounts of money or income or whatnot at birth and see what the impact is. Now, that kind of experiment is, of course, very tricky to do in principle, because we cannot just go around, look at a birth cohort, give some of the children some money and some of the children we don't give it to, and then we look at what the outcome is, and then we finally know what this relationship is. So we have to look for natural experiments. And natural experiments are basically situations where nature or society gives you an experimental setting by mistake. And one way to do that is to look at business cycles. This is the fluctuation in income and unemployment over time, which we know as recessions and depressions and houses and whatnot. And because no individual can generate a recession, if you're affected by a recession, this is an exogenous shock on your income. and also on the stress situation around you. So what we can do is we can compare cohorts that were born in a recession to cohorts that were not born during a recession, follow them over their life cycle, and look at the health outcomes that's being done. So this is a method that was developed by one of my colleagues, Gerard van den Berg, in 2006 roughly, and it has been applied since to many different settings. And here we were the first ones to apply this to cohorts born after 1950. Because you can imagine that you have to follow people for a long time. People were using data from the 19th century, from the early 20th century. But yeah, I mean, what does that say about today? So here we could actually, using the Lifelines data, say something about the current thing. So as I said, we look here at fluctuations in the unemployment rate in the different Dutch provinces. And then we look at how this unemployment rate at birth affects health later in life. And because as an individual household, you cannot affect this unemployment rate, we know that there's kind of an exogenous shock coming. So what we found here is that for women born during recessions, the cardiovascular disease risk, which we took here as an outcome variable, was elevated with respect to women that did not have that case. For men, we didn't find that effect. We don't know exactly why. Maybe also because men have a higher baseline cardiovascular disease risk, so we don't know that. What we did also see is that mothers who smoke during pregnancy, their children have a substantially higher probability of cardiovascular disease risk. So there's really this intergenerational effect going on here. And we did also, similar analysis with birth weight and with other things, and we consistently see this pattern that there is an impact of these economic conditions and birth at these health outcomes later. And this is something that we're pursuing now also with genetic data and whatnot. But this is something we can really do uniquely here in the Northern Netherlands because we have this big cohort. But of course, also if you have linked register data, you can go even further in that. Now, a really important thing is that we have all these differences, let's say, between groups in terms of health outcomes. And what we see is that what we really focus on in much of the literature is average outcomes across individuals in different socioeconomic groups. But these averages maybe are not so interesting. So what we see here, for instance, is the relationship between the price and the value of the house and the percentage of people claiming to be in good or excellent health. And the literature in general then says, okay, there's this upward relationship. So people in the higher income houses are actually healthier than the people in the lower income houses. But then if we take the full picture, then we see that there is a big distribution of outcomes within these groups. And that there's actually quite some individuals and neighborhoods who are in low income settings who in terms of health do as well as the average. And these kind of groups are actually very interesting because somehow they have broken the link between the economic position and the health outcomes. So it's good to learn from them what's going on. And to do that, actually, you need even larger data sets because you cannot rely on small groups anymore because you have to be able to cut the data in many small groups and still be left with large enough groups to say something. So I think that's really where the literature is moving towards now. And also we did a paper 2 years ago, or last year, sorry, where we looked also at, the difference in costs, in healthcare costs in different income neighborhoods. And what we see is that indeed, the poorest neighborhoods have the highest expenditure per capita. But again, there's this massive distribution. So there's quite some spread in these outcomes, so that there's also some low income neighborhoods that actually have, on average, lower costs than others. And it's interesting to understand where this is coming from, because what we showed here is that you can save almost €1 billion in healthcare costs by not even moving anybody to a different socioeconomic position, but by just flattening these distributions and making sure that these outliers are gone. And again, that's where you really need data to kind of zoom in. And this is a pattern that we see for everything. Right here on the left, this would be the amount of obese people by different educational levels. And what you would get is, yes, the lowest educational level, more people are obese. But then if you look at the entire distribution of the BMI over these educational groups, you wouldn't even draw these stark conclusions anymore. Essentially, what you see is that in the higher education groups, the distribution of health outcomes is narrower. So there's not these kind of fat tails where things are going on. But essentially, if you would make sure that these distributions got a bit closer to each other, you solve much of the problem that you see here. But you only see that if you look at full distribution data. And full distribution data simply requires also more underlying data because you want to get a bit deeper into that. So I think the conclusion for today is a couple of things. So, we really see that a large literature deals with differences in average outcomes across individuals in different socioeconomic groups, and there we consistently find this socioeconomic pattern. Now, we've known this now for almost 50 years, and we've not really been able to do much about it. And I think what we're moving towards seeing now is that the differences within these socioeconomic groups are so large that a reduction in them could actually improve the quality of life and save costs. So I think that the future research and policy agenda should really focus on understanding these origins of the health differences within the groups and focus a bit less on health differences between groups. And I think this holds, of course, in my example, because it's my expertise for the socioeconomic groups, but I think you can equally well, do this for different ethnic groups, different age groups and whatnot. So I think really moving forward, what we have to look at is these within group differences. And for that, of course, we need much more data than we have now, because we want to pinpoint where things come from within these groups. Thank you very much.
Okay, thank you, Jochen. A very interesting presentation. Are there any questions in between? I don't think so. I don't see anything in the chat. I don't see anybody raising their hands. So I think that most of it was clear. So maybe the content questions will come later. So don't hesitate to put anything in the chat already if you want to ask something in the end to Jochen. Thanks again, Jochen. And I'll move on to the next presenter. That is Maarten. Maarten is lead monitoring at HealthKick. HealthKick focuses on implementing population health management in the Netherlands. Population health management uses data from multiple domains to monitor health behaviors and do risk stratification. He is also the founder of Next Health, digital health strategy and innovation lead for patient-centered innovation at the University Medical Center Groningen. And Maarten wanted to start with showing a video on population health NL.
Anna is involved in her region's health policy. She wishes to investigate how to achieve more healthy years for its residents. Anna knows that health is determined by interactions between various factors. Furthermore, monitoring health and evaluating health policies requires multiple data sources. She discovers that much information is often difficult to access, outdated, and poorly linked. She asks Chris for help with her research. He makes use of the public infrastructure provided by Population Health Data NL. This offers him the most integrated dataset covering all the various health-related fields. Previously, he was forced to spend a lot of time linking and updating datasets. No longer. Moreover, he now has access to data that used to be much harder to obtain. Making full use of the available data's potential makes it easier for him to create an impact with his product. PHDNL's public infrastructure provides structured access to health and healthcare data and makes this available to all. It also offers a repository where developers can present tools and applications. Additionally, PHDNL is working on a learning community for users to exchange insights and experiences. Chris notes that another region has already performed a portion of Anna's required analysis recently. By reusing this data, he avoids doing the same work twice. Now Chris can use the available time and resources more effectively to create insights for Anna. Chris's findings allow Anna to draw up a data-based policy and enable her to monitor the health of her region's residents. They can now devote their time to their most important goal: achieving more healthy years for all residents of the Netherlands. Want to learn more? Go to populationhealthdata.nl.
So Jochen and I have been working together on basically the question what Jochen was mentioning already was how do you basically get the data that you need for your research but also for policy together so you can really work on it. And what we found out is actually that's a challenge that's been seen often and quite wide throughout the field of what researchers, policymakers and others are actually experiencing. I have to excuse that my slides are in Dutch, but I'll talk through it in English, because what we saw in our analysis of really working with population health data throughout the field is that there's a lot of people doing a lot of spending a lot of time on the data analysis. And if you ask people what they really are after, it's the insights that come from this data analysis. So sometimes 30 to 50% is spent on bringing together the data, cleaning up the data, normalizing the data, all these bits and pieces that are quite time intensive, but don't add a lot of value in the insights. So that's one thing that we saw when we were working on this problem. Also, the fact that several models are being built. As you might know from, for example, AI research or data science research, most people reuse libraries and tools that others have been building to do their research. Unfortunately, in the population health data community, not much of those tooling and approaches exist already. So we saw that there's also an apparent need for the reuse and also the sharing of those libraries, tools, basically all the things that you could use for your analysis and policy making. So to have some kind of repository would be beneficial to all researchers. And the third was also that we saw that a lot of communities for subspecialisms were quite well developed. So for example, again, AI communities or data science communities. But for the people who work on basically the verge of both practice and science, so a lot of the policymakers and people involved in assisting policymakers, there's actually quite little in terms of knowledge sharing. So if it's okay, I think you can see that I navigate through the slides. So on the third slide, you can actually see that we identified some problems with the current initiatives. Most of them were local. It took a lot of time and effort to get them going. There was also often the wrong level of data that was not the data that people needed because it took so much time for them to get data, for example, at individual level, at the micro level. And sometimes they had the data, but it's very hard to extract the data in such a form that they can really make policy based on it. Because there's so much time and effort involved, budgets and other time constraints were limiting people to go through with the real gist of their analysis. And through that, there was also basically a lack of learning abilities. So there were a lot of repetitive steps, and people just didn't get through the real stuff where they could really say, okay, this is my approach and I can really share it, because at the time they were there, almost all the budget and the finances were already depleted and used up. So that also means that it's very hard to keep projects going because they have to reapply again and again for small pieces of financing and resources with limited outcomes. And sometimes actually the reverse happens. So sometimes there's a really nice data model and an infrastructure built, but then people have built it for the sake of linking the data without asking the question, who is going to use this, why? And so that limits also the use, because if there's no end user, it's also very hard to keep going and to say why is there a need for this data infrastructure, even though it's well suited. It doesn't mean much if there's no people at the end using these resources. So we said to have a resource that can bring together the questions about public data infrastructure, sharing of knowledge, and facilitating the reuse of components would actually be beneficial. So we can actually add this to the Netherlands in terms of making people live more healthy years. Because ultimately to do that research and to apply it is what most people are after, not so much the basic bits and pieces of bringing together different components. So we're actually saying it's kind of a cycle. You have to bring data in the upper right corner. You have to link the data together. Then you have to apply the analysis and tools, maybe your own tools, but possibly tools others have facilitated or built that you're actually more or less reusing. That is what you're using to facilitate the insights for the people who are making policy or applying those insights that you've encountered into real life, and therefore creating the impact which you can then measure again with the data. So it can also be used for monitoring through long-term data and health questions, such as Jochen mentioned, that you want to have longer-term analysis for your health outcomes. So what we said is in this basically this animation, I saw that also the link was posted in the chat. So for those of you who want to look at it, we said is basically bring together these three components. And so the components are the public infrastructure, a repository, and a learning community. And so that approach could help make your research more cost effective. So you can do more gathering insights instead of working on the data. You can also do it more scalable, and you can do it more efficient, and you can also generate more impact. So the three pillars of the approach are basically listed here: the infrastructure, the repository, and the learning community. So what we're suggesting in applying this is basically, this might be somewhat small for some people to see, but the approach is we're bringing, if you look at the number 1, it kind of goes through the process from 1 to 8. We're bringing together these different resources basically in a regional data hub. And this regional data hub then can normalize the data, structure the data, and the regional data hub is supported in terms of governance and infrastructure by HealthRI. While some might know HealthRI, which stands for Health Research Infrastructure, it's a community of mostly university medical centers that already does this for clinical data. So for example, imaging data is analyzed throughout different medical centers in the same way, but no such infrastructure yet exists for health-related data, which can be a combination of data from the social domain, so municipalities, but also from the hospitals, hospital record data, or from, for example, individual data from monitoring wearables and other data tools. So you bring that together in a regional data point, and then you actually supply it through, at number 4, you supply it to the researcher or the local intermediary that is actually making this into an insight. So it can be an advisory body, an individual researcher. But now the steps at 1 and 2 are mostly done every time as a project approach. So every time a new research or new infrastructure is built, a new data model is being defined. And that's what we're seeing even with some quite advanced projects that are there. So what we're now doing is building a community of people throughout different projects that have already had experience, for example, bringing together CBS microdata, data from hospitals, anonymizing data, pseudonymizing data, all these different bits and parts, and bringing them together in 2 specific use cases. So for the Northern Netherlands, we're looking at the monitoring for the national prevention program in Groningen, the MPG, and we're also doing this in the Achterhoek region, where we do this for applying population health management methods. So by building a common data infrastructure, we can actually reuse the data model between the different approaches, and we can basically work on it together. So we're sharing the resources of developing the data model, but we're both using it for different purposes, which have a real customer at the end. So the MPG in Groningen, and also the Achterhoek region, where they invest money and want to see what the outcomes of their different interventions are. So that's a part of the public infrastructure. Then the part of the other part is, so to say, is what we call to go 1 slide back, the repository. And the repository is basically a resource where we can actually share already built tools and models from researchers and policymakers. So it could be that you are looking for data sources that have been used by others and that you could also apply in your research. So it is like a catalog where you can actually bring together knowledge about which data sources exist for policymakers at the population health data level. The second category is analysis and tools. For example, Jochen's Institute have made a comparison tool for different neighborhoods. So you can actually see which digital neighborhood is your digital twin, so to say, in terms of development. So what is likely or similar to your neighborhood, and why does your neighborhood differ in a way from other neighborhoods, for example, in the Netherlands? It can also be predictive models, such as the WMO. So the municipality aids people and supports people, for example, with health tools and other applications. So a predictive model can also be applied to other places and to other municipalities. So these tools are part of the repository. And also the third one is the outcomes. So for example, how do you define the outcomes and how you set up your measuring plans are also components that can be reused throughout research and policymakers. And the third part of population health data NL is basically the community part, where the knowledge that is being shared of how to develop the infrastructure and the tools is brought together in a community with different actors in this field. So they can be data sources, for example, from the insurer. They can be data sources from the municipality or researchers. And they can be people who have the question and are kind of acting as the, so to say, client in this question. So in this sense, we're doing the three parts of bringing together the community, supplying them with the right tools and access to the right resources, and also making a shared understanding of a common data model that we can use for analysis, so we can actually reuse these data models for further research and policy making. If you want to know more, you can go through Population Health Data NL. Also, the video that we started showing in the beginning is there in the Dutch version. You can find the English version on the YouTube channel if you search for it, or the link in the chat below. Thanks for your attention.
Thank you, Maarten, for the presentation. Very interesting topic also, the way you are able to connect people together and get them to share. That's not a very simple thing to achieve. Are there any questions from the audience? Either by raising your hand or by typing something into the chat window. Not until now. I've got one question for Maarten. So you said in the beginning that it was not common that information was shared, or that tools were shared, etc. How did you get all those partners that you now have involved in that whole national network to actually start sharing? Is it just putting up the infrastructure to be able to do it, or do you also need to convince them a little bit more that it's that it's better for them also to be more open about what they're doing and the data that they have, etc.?
What we actually found out is that there's a lot of willingness. So it's not a question of a lack of willingness or for example, keeping things close to their own. It's much the infrastructure which is missing. So to have a method of sharing these tools, and we're currently still negotiating what will be the best infrastructure, but just the lack of a place to share this. And so to say, the common data model. So if everything is built in-house, then it's built on your own data structure, on your own way of dealing with the data. So it's also not meant to share. So one step is explaining it, that it's valuable to share it all. So to clean up some of the code, to make it basically publicly usable. And then the second step is providing that infrastructure is just the easiest way to get them to share actually the tooling they've already built with others, which they're most often quite willing to do, because it also informs their own research and their own knowledge as well. Okay, well, it's good to hear.
There's one question in the chat now, I think also for Maarten. Can I state that this is an infrastructure that supports the learning healthcare system principle? It's a question from Michael van der Zel.
Yeah, and I think that's true. I don't know if there's a specific scientific definition mentioned for learning healthcare system, but in the sense that we're trying to do this is that it's basically a reinforcing, like the cycle that I showed in terms of learning. So with the outcomes and the access to tools, you're actually reinforcing the ability to learn and to basically build upon previous insights, which should be more reinforcing this this approach as part of a learning healthcare system.
Then there is a question from Suzanne. Do you also collect genomic data? If so, where does this data come from? Which parties, and how do you ensure privacy?
Yeah. So if you take an approach that we're like a stack, you know, in all the kind of technology, you have all these kind of stacks, whether it's the OC stack for networking layers, there's different layers. You could say that at the top of the layer, there's like the hyper individual micro level of individual data. And then at the bottom, there's kind of the national, you know, aggregate level where you see everything for just the whole of the Netherlands or the whole of the world or the whole of the European Union. We're kind of like right below the individual level. We're really looking at segments and groups. So for example, like Jochen were mentioned, people which have a lower social score or people with a certain age group. So we're really looking at risk stratification groups. And we're not so much in the business of gathering any of this data ourselves. So what we are trying to enable is that others are able to share their insights at a segmented level or a risk stratification level for specific groups. So we don't hold any data such as genomic data or not even wearable data as such, but we are interfacing much with those suppliers to allow them to say, if I would want genomic data, this has not happened, so it's more hypothetical at this point, but if you would want genomic data, I would want to have it for a very specific risk group that I'm analyzing. So I'm not looking for just anyone between the ages of 18 and 65, but for people who have also other conditions. So that's where the linkage plays a big role. So how can I help the people who have the genomic data to just find the specific group of people that I am actually after? So we're much looking at the aggregate level of a risk group in terms of the data that we analyze and hold. So it's also less invasive in terms of privacy, because we can only do, ultimately, we only publish or talk about groups in the end. But at the analysis level, in a closed and secure environment, you would need more micro data to actually link those groups together before you export the outcomes.
Okay, Suzanne, I hope that's clear. Michael, Susanna says thanks, and Michael also put his thumb up, so his question was also answered properly. There's a question from Nienke for Jochen. Lots of policies target lower SES groups. Is there much to gain by targeting within group differences rather than between group differences? Would you say that policies should target all groups instead of singling out lower SES people? What would that mean for decreasing socioeconomic health differences?
So I think there's a couple of things to say about this. So I think first of all, I think it's good to target the different groups, but I think the question is, how do you target them? Because I think that now a lot of targeting is aimed at looking for policy anchors that somehow explain the difference in health between lower income and higher income individuals. But I think you should target the different socioeconomic groups with policies that are aimed at understanding why there's differences within the groups. So I think you should design policies based on the comparison between, let's say, people in low income with good health and people with low income with poor health. What's the difference between those two? And develop the interventions based on that. But I think targeting the different groups, I think, remains smart, but I think you should target them also with an idea that kind of the solution lies in the group. What it means, of course, for the gradient is a bit of a is a bit tricky, because let's say you eliminate all the differences within the groups, then maybe the gradient stays the same, right? You could imagine that you just kind of get to a concentration in each group, that the spread within the group becomes the same, but that the spread becomes less, but that the mean stays the same. In that sense, you would have no change in the gradient, but there would be substantially more people who are healthy because you have a less distribution. So it's a bit of a tricky. It's a bit tricky to understand what exactly the impact on the gradient would be, but I think that maybe in general we should focus a bit less on the gradient itself and a bit more on, let's say, the underlying phenomena.
Okay, Nienke says, thank you. So I think the answer was sufficient to help her understand better about her questions. Are there any other remaining questions? I don't see anything popping up in the chat. So I think that we are going to conclude this session. I would like to thank Jochen and Maarten again for giving these interesting presentations. It's very interesting to see that we have all those different topics at the UMCG on data science, that we have a lot going on that not everybody knows about. So it was good to see that we also had about 50 people attending this time again. I think that Femke has a slide on the next webinar that we will be organizing. So that should come up soon. Yes, that will be on March 16. That will be in the evening at 7 o'clock, how to get more out of your data, data science in practice. So 2 case studies. We're going to discuss how researchers came with their data and how a group of the Hanse and also the machine learning lab at the UMCG took up those databases and tried to solve the questions that the users had. So you're all invited to attend there again. You will be informed. If you're not on our mailing list, then send an email to dash@umcg.nl to get included. And then you will be informed about our webinars and other activities. You can also visit our website or look at our LinkedIn page. The recording of the session will be on our YouTube channel. So if you want to review it or want to share it with someone else, please do so. And you can also subscribe to that YouTube channel so you will be informed when new recordings will be made available. So thank you all again. Thanks Maarten and Jochen again for presenting. Thanks to Femke and Brigitte for organizing this session, making sure that the technical stuff was running. And all of you have a nice lunch and a good remainder of your day, and see you next time. Bye-bye.
Bye.